Mr. Powell.
I am.
Mr. Bayesian reason.
It is mine exclusively. No one else has rights. I don't know if you guys can see people in the background or not, but anyway. I need to enlarge the chat. It's going by so fast I can't keep track of what's going on. And it won't let me. So Gene, just spam that you want me to start when you're ready for me to start talking.
Oh.
Hey Drew. Yeah, let's 12. I usually start at 12:05. So hopefully a few more people will join. I'm recording, so let's do it. I'm super excited.
I know, I'm excited too. And then let me get this minimized so I can see everything. So hello everyone. I'm sure some more people will be filtering in soon. Today we're going to be talking about something called Bayesian reasoning, which for math nerds, they're probably giggling in their seats, excited. For people who are not math fans but have heard of this, they may be getting a little uncomfortable. And some of you may be thinking, I don't know what Bayesian is or why I should care. But really what we're going to be talking about is kind of statistical models to help us make evidence-based clinical decisions. And that's really the fundamental idea here. And oh shoot, it's not letting me. Oh, there we go. Okay, perfect. And I have no disclosures for you guys. I'm not going to talk a whole lot about Bayes, his theorems, or the detailed math of what we're talking about today. The thing I want you guys to understand is that Bayesian reasoning is about taking a prior probability, getting new information, and then revising the probability based on that new information in a way that's accurate and useful. And in medicine, that primarily looks like this. You have a pre-test probability of a disease existing. You do some sort of diagnostic test, you run an exam, whatever that may look like, a procedural exam, and then afterwards you have some sort of revised probability for what's going on. And that's the fundamental idea that we're going to be talking about today. I don't want to focus on math. I don't want to focus on things that are hard to calculate. I want to focus on useful ways to incorporate this kind of reasoning into our clinical decision making. So our learning objectives for today, the first one is I want you guys to be able to generate specific pretest probabilities as well as action thresholds for clinical scenarios. We'll get into the details of that in a bit. We also need to be able to use likelihood ratios to arrive at an appropriate post-test probability. And then the last thing that you see here, if we have some time at the end, I'd like to talk with you guys a little bit about smartphone apps that may make this a little more accessible to you guys. And then the last thing on here, it's June. For the medical students who are on here, you're going to be interns soon. For the interns who are on here, you're going to be seniors very soon. And there are going to be people who don't know about this stuff. And it's going to be really important for you to have an understanding to teach these basics. Because I think as you'll see as we start talking today, a lot of what you already do in medicine is using these things that we're going to talk about today. You're just not using them directly and in a way that you're using in a way that you have understanding of it. So I just want to start off with a case. So it's January, pre-COVID. A 17-year-old female with a history of asthma comes in with cough, malaise, rhinorrhea, a mild headache. She's got a fever, pulse is a little bit high at 95. Breathing is okay, blood pressure is okay. She's sitting a little low on room air. On exam, she's non-toxic. Normal work of breathing, mild to moderate wheezes are heard throughout her lungs, but no crackles. And otherwise, she has a normal exam. And so the initial question that I would kind of postulate to you guys is from 0 to 100%, how likely is it that this woman has influenza? It's January and she's got kind of pretty typical symptoms. And so just think for about 10 seconds, what kind of likelihood you put on. If you want to put it in the chat, I can't see it, but that's fine. But think about how likely is it that this person has flu with these symptoms. Okay, so you're in the ED. They send a rapid flu antigen test, and it's negative. Now, how likely is it that you think she has influenza? Well, it's kind of a tough question to ask, right? A lot of you probably were thinking she's got a decent chance of having flu. Numbers may have ranged anywhere from 20 to 80%, depending on how much you were worried about other viral illnesses. But most of you were probably thinking she's got a very flu-like sounding illness. And the way that we can figure out how probable this is, sensitivity and specificity, right? The math of all this evidence-based decision-making. But you look at these numbers and you don't really know what to do with them, right? You can see that, oh, well, maybe we're going to miss some people, but it's pretty accurate, right? It's got good specificity. What am I supposed to do with this information? And that's kind of the hard part where the disconnect happens, right? We send these tests and we don't always know what to do with them. And that kind of brings up the big issue that we're going to talk about today, which is the probabilities of things happening in medicine. So ranging from 0, impossible, to absolute certainty. How sure am I that this patient has a diagnosis? And sometimes it's something simple like the flu. Sometimes it's something far more complicated, like a type 1 pulmonary hypertension or a very unusual kidney condition. But how sure am I that our diagnosis is there? And falling right in line with that is the issue of thresholds, which is really a question of how sure do I have to be to treat? How sure do I have to be to test this person further? Or how sure do I have to be they don't have it before I send them home? And so these are questions that we ask ourselves every day, but a lot of times we do it without looking into the actual data of why we're coming to the conclusions we have. The last thing that I'll point out here on statistics is likelihood ratios. I know you guys have seen these formulas before. I'm not going to ask you guys to calculate these at all today. I know that this is something you guys know for your STEP exams and then later for boards. But at the end of the day, these likelihood ratios are really where the rubber meets the road on what we're trying to do when we test people. We're trying to figure out, is this helping me confirm or exclude a diagnosis? And to what degree is it able to do that? Am I running tests that are useful and actually affecting my decisions? Or am I just doing things because I'm supposed to without knowing how they actually affect things? So let's go back to our flu test. We had 70% specificity, sensitivity, and 90% specificity. Here we can see this little diagram. The plus is positives, the minus is negatives on the test. And if we take 10 people who have the disease, this is the rough distribution that we would expect on average with a sensitivity of 70%. It's the percent of people with the disease who test positive. On the other hand, if we take 10 people without the illness, you can see that 9 of them test negative, 1 test positive, and that's how we end up with our specificity, the percent of people without disease who test negative, 90%. But we have a patient who's not some randomly tested person or a person who we already know, right? We have information about this person. And what does a positive test mean for our individualized patient who we already have information about? Furthermore, what does a negative test mean? These are the challenges that aren't answered by these numbers of sensitivity and specificity directly. And so if I have a positive or negative test, how much more or less likely am I to have X condition? So if we get a positive test, our little yellow dot, our patient is on the positive side, how much more likely are they to have the disease? If you do a ratio of people with the disease to people without, you can see that it's actually pretty simple math, that you get about 7 to 1 or 7 times more likely to have the disease. And you can see that if you actually did the math on the likelihood ratio, you get actually a value of 7. Similarly, if you have a negative test, how much less likely are you to have the disease? It's the exact same thing here. We're taking the diseased population over the non-diseased population who have negative test results. And you can see that you have about 1/3 as likely to have the disease based on the sensitivity and specificity we've outlined here. And you can see, again, the calculation works out. But how do we use these things? How do we actually take those numbers and do something valuable? I want to introduce you to something that I think is one of the coolest things ever. It's called a Fagan nomogram, but the name isn't that important. The important thing is knowing what you're seeing here. You have a column of three separate columns of numbers, and on the left, you can see at the bottom you have pre-test probability. In the middle, you have likelihood ratio, which we just calculated, and on the far right, you have post-test probabilities. Okay, and the way that this nomogram works is actually really, really amazingly simple. If you chart your pretest probability, so let's say with this person with really typical symptoms, we thought they had a pretest probability of maybe 50% of having the flu, 50% of some other, viral pathogen, and maybe a small percentage of, atypical presentations of more concerning things. Well, a likelihood ratio of 7 puts us at plotting a line from 50% through the 7 in the middle and gives us a post-test probability of 90%. So this person now has a 90% post-test probability of having this disease based on a positive test result. Conversely, if we do the negative likelihood ratio, we can see that we've gone from 50% probability to only 20% probability. But that still leaves us with a question, right? What do I do with these numbers? What does 20% mean? And I think this is where a lot of people kind of get stuck with using this kind of data, is they end up with a number, but they don't know what to do with that number or what the significance of that number really is. And that brings us to the second part that I was talking with you guys about before. This is all the probability, but the probability is useless without thresholds. And what I mean by thresholds is setting up a standard in your head. This is not something that comes necessarily from a textbook, but a threshold for where you decide, in this example, I think it's so low probability that this person has the disease that I don't need to treat them. Or it's so likely that I do need to treat them, right? Maybe 80% is your threshold to treat a disease. And in the middle here, we kind of have this nebulous space, right? Where I kind of want to get more information. I don't feel confident enough to actually commit to a pathway of treatment or a pathway of therapy. And these things that we call thresholds are identified by you. And it's important to understand that part of your job as a clinician is to create these thresholds because you're doing it every day. When the patient comes in and you say, well, we could give them antibiotics, or we could do this, or we could do that, you're creating those thresholds. You're just doing them kind of with your gestalt instead of with an actual practical purpose in mind to say, this is where I feel confident enough to make a decision. Some illnesses are going to have very different levels of threshold, right? So for example, here you can see that there's a very small area of uncertainty, and that we can kind of come up with definitive treatments one way or the other more easily. And these are instances of low risk diagnosis or low risk therapies, right? You don't have to be as confident treating strep pharyngitis as you do something else, because even if it's only 40% that they have it, right? That's enough likelihood. Antibiotics are low risk enough. You're willing to treat that person. Similarly, if you think it's only a 10 or 15% chance that they have it, you're comfortable in not treating that person because you know that they can follow up easily, that the likelihood of them having a significant complication is low. But conversely, there's diagnoses where the thresholds are completely different. Think of these kind of thresholds as things for things like PE. I know a lot of us who've been in the hospital have seen some pretty significant side effects from anticoagulation. As an intern, I had 2 separate individuals go to the ICU for massive bleeding from anticoagulation I had started for PEs. And so we require a lot of certainty before we start people on therapy for these things because of how high risk they can be. And so it's important to understand that these thresholds are, 1, set by you, the clinician, and 2, differ depending on what kind of diagnosis and what kind of therapy we're talking about dealing with. So if you kind of map this out to the other side of the board, you can see that we flip as we cross the nomogram. What we can do is, if we establish thresholds before we run tests, we can come up with really effective tools that actually direct our clinical decision making. And so a test may be really, really helpful. And a positive test tells us, yes, we need to treat. And a negative test tells us, you know, we don't need to treat. And this is kind of an ideal test right here, right? Where you can run that test and come to a conclusive answer on what you need to do. Sometimes, though, tests don't work that way, as we all know, right? Sometimes a positive test doesn't tell you a whole lot, but a negative test tells you a ton. And so we can see the converse of that, a positive test being very useful and a negative test being less useful. There's a whole variety of ways that this can work. And the importance is understanding how useful it is. A lot of times we run tests and we know the general way we're supposed to interpret them, but we don't know how significant their effect is supposed to be on our final decision making because we haven't taken the time to sit down and say, what are my thresholds and what does this mean? You'll also find that over the course of your career, your threshold for doing things changes, and different clinicians may have different thresholds. And if the idea of that makes you uncomfortable, I'd like to remind you that it's always been this way, and that these differing thresholds is why we have such rigorous training and why we spend a lot of time talking with other physicians, because you may have here in our patient who was likely to have the flu, this first column on the right, you may have an intern that says, I really think we need to get a flu swab, whereas an attending on the far left may say, the flu swab's not necessary, we just need to treat. And so every diagnosis is going to have different thresholds, and every clinician may have different thresholds. But the importance is identifying that the threshold is there either way and making sure that you're making decisions based on a threshold that you've actually decided to act upon instead of something nebulous that you don't necessarily know how to interpret or don't necessarily know how significant it truly is. A lot of people ask, how do I know a test likelihood ratio? Which is a very good question. When I order a CBC, I don't get a sensitivity specificity range for detecting anemia. I don't get any of those things, right? But the data is out there. It is accessible, and I promise you, you can find it. UpToDate and PubMed oftentimes have great resources. These are two websites that have a lot of great resources on them. And there's all sorts of clinical review articles on laboratory testing for identification of diseases. So they are out there, but you do have to look for them. And the last thing is, and I've kind of already been talking about this a little bit, the arbitrariness of what we're doing here. There's a lot of concern because you're picking these numbers, and they're not numbers that were taught to you, right? Nobody ever taught you, well, when you have a PE, you need a threshold of X%. But that's because they are arbitrary, and that's okay. The way that you know that you're right is, one, you know the patient, you know what symptoms they're having, and you know what kind of things are affecting them. You know where you're at, you know your geographic distribution, you know the things that are likely to happen to your patients. You know all these things. You know what things are risky that you're concerned about and that you need to be certain are not present. Like we talked about before, if someone has a 20% risk of PE, most people are not going to say that's okay for no further investigation. Most people are going to say this is really serious. And then lastly, you have experience. You have this kind old physician, that's experience of yourself, experience of your teachers, experience of other residents who really help make sure that you know what you're doing. And that's really what this is all about. Clinical prediction rules actually is something that's very prevalent. These are things, I'm going to go forward just a bit here, like the Wells criteria, the Centaur criteria, the PERC rule. I'm sure a lot of you guys have heard of these kind of things. All these are is ways that we've started to standardize this decision making. And so this is kind of my way of reinforcing to you guys that you are already doing this kind of decision making. It just hasn't been explicitly expressed to you. And the advantage of these kind of things are multifold. They help you avoid bias. They account for more factors than you may have initially considered. But the disadvantages are that they're not always user-friendly. And if patients are having sudden clinical changes, you can really see a lackluster response from these clinical prediction rules because you really have to reassess the patient frequently when things are changing. I want to show you kind of an example of these clinical prediction rules. So I have another case for you guys here. You've got a 16-year-old high school student. She's got 6 days of cough, congestion, a little nausea, some sore throat, but she's afebrile. Her throat looks totally fine. She's got clear lungs, no lymphadenopathy. But she's like, Doc, I've had strep throat before, and this is strep throat. It's really bad. And so what do you do next? Take a second to think to yourself, what do you do with this lady? What are you going to do next? Well, regardless of what you wanted to do next, you performed a rapid strep test, which came back positive. I'm sure a lot of you, especially if any of the MedPeds folks are watching, probably would not have done that. Some of us say, well, it's better to know than not know. And so if we have this information, what does it really mean to us, right? If we have data, what can we do with that data? And what do you do with this now positive test result? So this is a really good example of the Centaur scoring criteria. The Centaur scoring criteria is a really neat tool that was created to help diagnose group A strep pharyngitis using a scoring system. You can see there's points here on the right-hand side for different findings. Our patient had 0 points on this score. And if we look at this nice little diagram here, it's a really good table from the paper on Centaur scoring, you can see that they've actually done the math for you. A score of 0 correlates to 1 to 2.5% risk of actually having group A beta hemolytic streptococcus causing an infection. Whereas if you go all the way to the right side, a score of greater than 4 leaves 51 to 53%. And you can see here how literally the experts have formulated this scoring system to directly create this kind of clinical decision making that we've been talking about. And you can see the folks in the middle where the likelihoods are less certain, or the probability is less certain, that you're more likely to test, to confirm. Whereas if it is very high likelihood, you're more likely to treat empirically without further testing. And so our patient fell in this score of 0 range. So we can say our pretest probability is around 2-ish%. And normally you would say no further antibiotics or testing is indicated, right? It's so unlikely that it is safe to not treat this person. But when we test them, what ends up happening with our likelihood ratio of 7, all we've done is get ourselves into this range where we don't know what to do, right? It's data that we don't know how to interpret. And I think a lot of us have had this discussion before with attendings, with other residents, where we say, I wanted to run this test, but I just didn't know what I would do with it, right? And so, that's kind of where these questions really come in, is how do we interpret these things and what tests are useful? And if you don't sit down and do this, for something like the Centaur criteria, it's easy. For other things, it's really challenging. If you don't sit down and take a look at this, you may start making clinical decisions that aren't reflected in the evidence and don't actually lead to effective diagnostic techniques. 2 quick points. Physical exam findings also have likelihood ratios. We are both better and worse at the physical exam than we think, but most of us don't actually know the data on it. This is a great book from JAMA on the rational clinical examination. There's another awesome book called The Evidence-Based Physical Exam, and both of those are really, really good source materials for how accurate physical exam findings are and how useful they are to making diagnoses. And the other thing to know about physical exams, as well as any type of test like this, is you can't double dip, okay? And what that means is once you have done a test, an exam maneuver, it is now influencing your probability of disease, the calculation that you come out to in your head. And once you've done that, you can't then back up and say, well, what would it be like if I were to do this test and apply these strategies, right? You've already done it, and it's already affecting your clinical judgment. So what you have to do is you have to sit down and say, what's my likelihood? Which requires you to sit down and say, what tests are going to be the most valuable? You set your pretest probability. You do those couple of quick tests that have the most yield, and suddenly you find that you're able to really significantly affect your clinical decision making. You may find that you're not doing as much workup as previously, or that you're doing more workup on patients who previously you would have just kind of attributed to the most common cause or condition. But you can't apply the same test twice because then you're confounding the statistical effects. So I want to show you one more example here that I think is a lot more useful to kind of the inpatient medicine that we generally deal with. I know a lot of you watching don't do a whole lot of outpatient yet for you interns, but you've got a 62-year-old man who shows up in your ED. He's feeling kind of malaised, fatigued, he just doesn't feel himself. And the ED calls you, they say, hey, we want to admit this guy to you. He's got an AKI compared to some random labs from a year ago. He also has some leg swelling, he's short of breath sometimes, but his chest x-ray is normal. You ask more questions, but the patient has no known past medical history, and the ED doc tells you he's a poor historian. And you roll your eyes, you go, okay, I'll come deal with this. And you go down, you interview the patient, and you find that he is indeed a very poor historian. He has a hard time answering your questions in a way that's really useful. He tends to ramble and digress to other subjects. But you do think he is having some shortness of breath. He definitely has some leg swelling, and you're concerned that maybe he has heart failure. You ask yourselves, the team gets together, and you say, are there any tests? Is there any exam maneuvers that we can perform that might make us confident enough in our findings to start him on treatment for heart failure tonight? So you do some quick research. You think, well, maybe this whole finding of edema is enough to sell it for us. But pretty quickly, you see that the research on edema shows you you don't really have any clue what's going on with this guy based on his leg swelling. It's not really specific enough to make any type of diagnosis, and you're kind of left saying, okay, we got to investigate this further. And you know that elevated central venous pressure is a hallmark characteristic of both pulmonary hypertension and CHF. So that may be a really useful tool for you to figure out what this guy has. And you see with a little bit of research that detecting a central venous pressure of greater than 8, which is abnormal, using bedside measurement has a positive likelihood ratio of about 8.9, which is actually really, really impressive. A negative likelihood ratio of 0.3, which is not bad, but you think, okay, maybe this is pretty good. So you sit down, you create your thresholds, which is an important step here. You have to sit down and say, this is where we feel confident treating. We think we want to be at least 60% sure this is heart failure or a congestive lung problem that's contributing to this before we treat. And so you start off with 20%, and if he has a positive finding, you see that you get a pretty good value of about 65 to 70%. If this guy has elevated central venous pressure, a high likelihood that he has that. And then you can see the negative likelihood ratio takes you down to probably saying pretty confidently that he doesn't have elevated pressure. So it's a pretty good exam maneuver if you can find his actual vessels. So seems really, really helpful. But who needs the physical exam, right? Your intern, very smart, very bright, brings up that you can easily test for heart failure using a BNP. All we got to do is order this one test, boss, and we are going to have this figured out. And you can see that your likelihood ratio to diagnose heart failure with a BNP measurement cutoff of 100 has a positive likelihood ratio of 2.8, which is not great. It's okay, but not great. But a negative likelihood ratio of 0.07, which is exceptional. 0.07 is a really, really good negative likelihood ratio. And so you set up your table again, and you see that a positive likelihood ratio doesn't really get you anywhere. The BNP does not help you make the diagnosis of heart failure. But it really, really effectively helps you rule out heart failure. And so all of a sudden right here, we've got a really good idea of just 2 quick things we can do to try and figure out how we need to approach this patient. And the fact that we can, with a single laboratory test, have the chance of almost certainly ruling out heart failure is really, really helpful. The important thing to note here is we talk about things like BNP all the time. And when we talk about it on service, it's guiding our clinical decision making, but a lot of times we're kind of left with this question of how significant is this positive BNP? You know, the BNP comes back at 200. What does that mean? And a lot of times we don't have clear answers for it. And the reason we don't have clear answers for it is because we haven't taken the time to figure it out before we even tested for it to begin with, which is a really, really important thing to understand. I know a lot of you probably feel uncomfortable at the idea of doing this. For one, it's more work. End of story. It's more work. It's hard to do things in a way that is evidence-based. It's not easy. On top of that, we hate giving numbers. Not only do we hate giving numbers, we hate that there are numbers that we might not know that might potentially be useful and having to find them and being uncertain in them. We like it much better when we can point to generalities to help guide our decision making. 1, because it's simpler. 2, because patients sometimes understand it more. And 3, because sometimes we understand it more simply and better. We think it takes a long time. I would challenge you guys that it does not take as long as you think. And one of the things that I'm working on is trying to compile some resources for you folks to really get a better, more quickly adaptable way to do this kind of evidence-based decision making. I'll pull up here in a second, try and show some of you if we have time. But I think this doesn't have to take as long as we think. For those of you that know Akil has quite a backlog of dot phrases to help ease our lives. And that took a lot of initial front work, right? But the amount of time that Akil and everyone else has saved by that work is immeasurable. And so front loading your work here is the important part. It's being able to continuously re-access information that is useful. Another reason people get uncomfortable, most of us didn't have this explicitly explained to us when we were training. It definitely wasn't a big part of my internal medicine training as a medical student. My 2 months on wards, I had one physician who said, hey, if we think this guy might have acromegaly, maybe we should figure out how useful this test really is. And that was the one time that we did anything like this in the entire 2 months I was on, where we really sat down and said, what do the numbers say about this kind of test, and what can we really take away from the result? A lot of times folks get really, really caught up in the fact that they're kind of putting their gestalt on the back burner and allowing evidence to really take over. And when things don't turn out the way you expected them to, people really get uncomfortable. The way that they practiced may come into question. And I would challenge you that that's a good thing. As interns, I think we're a lot more open to this because we're not supposed to know everything. And new interns are, I feel like most of my intern class and most of the interns I taught this year are all really malleable. They're really receptive to trying to figure out what the heck's going on. But once you've started to figure out what the heck's going on, you don't want to be perceived as not having it figured out. And I would encourage you to know that that should be happening for the rest of our careers. You should be challenged in the way you practice medicine and have dysphoria about, am I really doing this the right way? Because otherwise, you're not going to make sure you're doing it the right way. And the last thing here is it feels odd to merge subjective data with objective data. And that's an understandable kind of complaint about this. And the biggest thing I would say with this concern is that you're already doing it, right? The things that the patients tell you are most of the time subjective. Your physical exam is not 100% perfect, though it is far more objective. And you're combining subjective and objective data already to come up with differential diagnoses and initiate treatment. And what I'm challenging you to do is add more objectivity to that. And I think that that's an important thing to understand about this, is that objectivity really can help improve your clinical decision making and help your understanding of why you make the decisions you do. The last thing is we don't speak in a language that makes this easy, right? A lot of the stuff we're talking about, sensitivity, specificity, they're words we throw around, when it suits us, but they're not necessarily words that we use to really describe what's going on. We don't talk about, the likelihood ratio and that we're expecting an increase of 15% in our pretest probability. We don't say those kind of things, and it makes it hard to start incorporating those things because sometimes we're not sure how to say it. And the only way to get better at it is really through repetition and practice. Ways that you can be better at this, questions that you can use to help apply these things to your practice. What is the probability of this condition right now, right? Just ask yourself that question when you're evaluating a patient. As you hear their story and you come to the end of what they're saying, really just say, what is the probability of this condition right now? And then go through your exam and then apply those exam findings to what you've been discussing with the patient. Be sure to ask yourself, what does the probability of this condition need to be to act? How sure do I need to be that they have a PE? How unsure do I feel comfortable being if they have a PE? And sending them home. Those are all very important things that you have to ask yourself to do this right. And I would argue that you should be asking yourself anyway, even if you don't have statistics available to you in your active practice. And then lastly, what is your probability of this condition after the test results? What is the likelihood that this person really has this condition? I also find that patients are really receptive to this. They're really receptive to the idea that that you're working with limited information and that you are trying to come up with the best decision based on what is most likely. Very rarely have I had patients be upset that I don't have specific answers if I've sat down and talked with them about the fact that there are multiple possible answers that we're investigating. So in conclusion, Bayesian reasoning is really helpful in navigating difficult diagnostic decisions. And it makes diagnostic reasoning explicit for learners. It helps people understand why we make the decisions we make. And it also helps ensuring proper interpretation. Make sure that when we order tests, when we run laboratory studies, when we do physical exam maneuvers, that we're not giving them too much credence or giving them not enough credence. And the last thing I'd like to talk to you about today is some smartphone apps that can help integrate. We definitely have some time. And so here's a list. If you guys want to screenshot it right now, you can. But if you just Google Bayesian reasoning, evidence-based decision making, you can find a lot of these things. The top one is my favorite free one, DocNoMo. But there's a few other ones. This one is my favorite one because it's free. It works on iPhone and iPad. It has very few bells and whistles, but it's simple. And you can save tests. And so you can literally put in, this is my likelihood ratio for this. So you can come back to it again and again and again. And you can really create things as being a part of your practice, which is helpful. here is a nice depiction of it. You can see at the top, there's the little red, I think you guys can see the mouse, but there's this little red thing at the top and the blue thing on the top on the right-hand side. When you set your pretest probability, this is just a Fagan nomogram like we talked about before. You can set the pretest probability, you set the likelihood ratio, and then you come out with an answer on the other side. It's very quick, it's very easy. All you have to do is know the likelihood ratio, which I would argue is not as difficult as sometimes we think that it is. But it's very, very helpful. RX Bayes, I love this site. It's awesome. It is not free. So the tests that you can see over here on the left, those ones are included in their kind of like free trial. They have like Joule examination as kind of an example of the idea of the data and how the data works and is interpretable. But they have a lot more options if you're willing to pay. But I don't think you necessarily have to pay to get good function out of these things. And the last thing that I want to tell you guys is I'm working on compiling information for you guys to help more effectively add in these things to your practice. The hardest challenge about this is, you know, a lot of times you don't have access to what you're looking for. And so I'm going to be working with Gene to try and help make that stuff accessible to you guys on the Silver Fridge. I've got a PDF that I've set up that we may send out to you guys or just upload to the Silver Fridge. It's a really good summary of what we talked about today with a little more detail and kind of how to more effectively use these things. But then I've also got some stuff for heart failure that I've been working on with a really kind of exhaustive look at the usefulness of both physical exam and diagnostic testing in heart failure. And I'm going to keep trying to expand these things for you guys because I think this is something that we can really make a difference in patients' lives and in our own education by incorporating these tools. But I hope this has been useful for you. And I don't know if anybody has any questions. Probably not. A lot of this is stuff you guys know. Any questions, anybody? If there aren't any questions, let me, I'm going to pull up this PDF real quick just to show you guys. If I can get to it, because I think you may find it useful. Glad we have a little bit of time left. Oh, well, never mind. My computer appears to not be working anymore. Well, I guess that's all I've got for you guys then. Yeah, if you have questions or anything, let me know. I'm going to work with Gene to get these PDFs available to you guys because I think they'll be really useful. They're only a couple pages long and mostly pictures and tables. So they're very quick and easily accessible, and you can kind of start creating your own evidence-based outline for yourself. So let me know if you guys need anything. And I think that's it for me, Gene.
Wonderful. Thanks, Drew. That was fantastic. Yeah, I'll recorded this, so I'll send this out, the whole talk for everyone, and then post all your materials on there as well. And I'm excited to see what you make for the heart failure thing so we can add it onto the module.
That'd be awesome. That'd be awesome. Thanks so much, everyone. Have a good rest of your day.